I'm going to start by talking about the four main infectious diseases that OSHA wants us to cover. We'll talk about AIDS, we'll talk about hepatitis, tuberculosis, and then tetanus at the end of it. I want to do something a little bit different than the classic presentations. A lot of them are really designed to kind of scare the living daylights out of you, or if they don't do it intentionally, they kind of do it as an aside. So I want to talk a little bit about the history of infectious diseases and blood-borne pathogens, how they really came into being, and just so you guys are aware of some of the main points of them. The big one that I want to talk about is the history of AIDS. That's really when we started getting into our advancements in blood-borne pathogens awareness and personal protective equipment, etc. So HIV, AIDS, it was first discovered in the United States in the late 1970s. A lot of doctors in San Francisco and New York City, they were discovering that a lot of homosexual men were developing very rare opportunistic infections that normal, healthy people with good immune systems should be able to fight off. So the CDC picked up on this, picked up on the medications that were ordinarily prescribed for these kinds of infections, these types of pneumonia, and they started kind of issuing a public health emergency based on that. Some of the initial misconceptions of it were that that AIDS and HIV were only caused by homosexual behavior, that they were only present in those. Some of the other rumors were that they were caused by poppers, that the best evidence against infection is heterosexual behavior, and that there's no danger to anybody else besides homosexuals. Clearly, we know a lot more about that now, but that was kind of the suspicion back then. A lot of discrimination toward that particular group of people resulted in not so much research being done. Really didn't start until heterosexual individuals, hemophiliacs, started to contract HIV and started to develop symptoms of it. So throughout the early 80s, there was a 20-month-old who died of AIDS because he received a blood transfusion. In 1983, the CDC retracted their previous statements about only homosexuals being able to contract HIV, and they started doing a lot more research. The big thing that really pushed forward the drive to go into research about HIV and about AIDS was a kid named Ryan White in Kokomo, Indiana. He was a hemophiliac. He received a blood transfusion and developed HIV as a result of that. There was a lot of really negative stigma about AIDS at that time, and then in 1984, when it became public that he had HIV and AIDS, he was expelled from the school. There was a big lawsuit. There was a big media scourge about it, and eventually there became a very big AIDS awareness campaign based on that. A lot of the research that the CDC did, a lot of the conclusions that came out of that was really the birth of how we developed our infectious disease protocols, how we developed our personal protection. It really kind of brought into light that we can and we are at constant risk of being exposed to these kinds of diseases. So in 1990, the Ryan White Care Act was enacted by the government. The bulk of it is the allocation of federal funds to people who don't have access to insurance, who don't have access to health care. But one of the stipulations of this as emergency health care providers is that anybody who gets exposed, who has a potential exposure, so you get stuck by a needle, you get contaminated with somebody else's blood, by law, that individual has to give up some of their own blood to be tested for potentially lethal and life-threatening illnesses. So this includes hepatitis, this includes HIV. They don't even necessarily need to be HIV or hepatitis positive. Every single emergency worker is covered under this, so if you do get an exposure, you have the right to know if they're carrying any type of life-threatening illness. So you should all be aware of that, and it should always kind of be on the forefront of your mind if you ever do get exposed. So some of the key points of the AIDS epidemic: widespread awareness that every individual can contract a blood-borne pathogen. It doesn't matter about your sexual orientation, your age, your gender. One of the big things that also happened is that blood donor centers really got aggressive and vigilant about testing their stocks of blood. It was estimated that between 1979 and 1984, about 90% of those individuals who received blood transfusions contracted HIV. Big proportion of those also contracted hepatitis C. Back in those days, they didn't really screen for blood. They didn't ask any questions. they would actually give you money, $50 to $100, to go out and donate a pint of blood. So this attracted people who were kind of desperate for money, living in lower socioeconomic status, and who were much more vulnerable and prone to have infectious diseases. So after the AIDS pandemic, a lot of that stopped. If any of you have given blood, you guys know that they ask you all sorts of screening questions before they'll even allow you to give it. If you've had a tattoo or a piercing in the previous 12 months, they won't allow you to donate. If you have ever had sex with another man, they also won't let you donate for the rest of your life. If you've visited certain countries that have a particularly large prevalence of infectious disease, they also won't let you. So they're very vigilant about that. They draw samples from you in addition to the pint that you give in order to screen you for hepatitis and HIV and several other blood-borne pathogens. So the rate of contraction for infectious disease after the AIDS pandemic has really gone down dramatically. So some of the other things that came out of that was the mandatory offering of hepatitis A and hepatitis B vaccines for any type of healthcare or emergency worker. So I'll talk about hepatitis in just a little bit. The HIV/AIDS pathophysiology, the way that it works is that it compromises the immune system of anybody who's infected. So anybody who has HIV, this particular virus attacks the immune system, and it attacks 4 types of cells in particular. The T cells are the cells that it attacks. These are what's responsible for really activating the immune response and killing any type of infection that really comes into your body. So you have 4 types. You have the cytotoxic T-Cells. These are ones that when you discover a pathogen in your body, they secrete an enzyme that kills that pathogen. It's kind of a non-specific thing. It doesn't really discriminate between what type of infection it is or anything like that. It finds something that seems foreign and it kills it. These are coordinated by the helper T-Cells. These are really the ones that coordinate the immunological response, and they coordinate between the cytotoxic T-Cells, and they also send out memory T-Cells. What the memory T-Cells do is that they remember the particular pathogen. So suppose, for example, you catch a cold, your body will send out its immune response to fight that off. The cytotoxic T-Cells will kill it. The memory T-Cells will remember the exact coding of the DNA and RNA sequences so that if you ever come into contact with this strain again, your body can kill it right away. So once you fight off a particular strain of cold, you will never get that cold again because of your because of your memory T-Cells rather. Then your final type are going to be the suppressor T-Cells. These are the ones that basically put a halt to all the other ones and stop the immunological response. So these are the 4 that hits. These are the 4 that it works on. And once you lose a certain amount of all 4 of these, that's when you start to develop these opportunistic infections. Like I was saying, HIV attaches to the T cells, it kills them, but it also replicates itself in the process. The more and more of the virus gets concentrated in the blood, the higher the quote-unquote viral load is. The increase in viral load is really what causes the increased transmissibility of HIV. So if the HIV viral load is low, there's a much lower chance of contracting the virus if you're exposed to any of the particular types of fluids that transmit the virus than if the patient has a high viral load. So you have this disease for many years. Depending on the type of antiretroviral therapies that you're on, you can last longer and longer. When the T cell depletion inhibits the effectiveness of the immune system, when your T cell count drops below a certain point, that's when you become vulnerable to the opportunistic infections, and that's when you acquire AIDS. AIDS is not a disease, it's more of a description of the immunocompromise that you get with advanced HIV. So once you get that, your immune system is totally impaired. The T cells that would ordinarily work on their various things, they don't work anymore. So your memory T cells, going back to that cold that you had, it won't remember that particular strain, and you can get that one again. The cytotoxic T cells those particular T cells, they won't destroy pathogens anymore, and the helper T cells can't coordinate the immune system anymore. So what you wind up getting with this is increased vulnerability to things that an ordinarily healthy, good immune system should be able to fight off. Salmonella is a big one. Tuberculosis, we'll talk about that in a bit, but people with AIDS are about 200 to 300 times as likely to develop tuberculosis. Their body can't fight it off anymore, and they wind up getting that very easily. Candidiasis, it's a form of fungal infection. You and I and people with healthy immune systems, we're able to fight that off. We're exposed to it all the time. But when your immune system gets compromised, your body can't fight it off anymore, and that's where you wind up getting it. These two, the pneumocystitis carinii and gyrovicii, never really sure how to pronounce that. Those are the two that usually kill AIDS patients. Those are the ones that they contract quite often. Number one cause of death in AIDS patients is pneumonia. It's usually one of these two. These are fungal pneumonias, and again, people with ordinarily healthy immune systems are able to fight this off without a problem. We're exposed to these all the time. And then Toxoplasma gondii, it's also called Toxoplasmosis. This is a type of parasite that's usually found in undercooked meats. It's found in cat feces, and again, a normal healthy immune system should be able to fight these off no problem. Also, AIDS patients tend to develop cancers very easily. One of the main effects of T cells is to kill cancer cells. So if you can't do that anymore, you're far more likely to develop lymphomas and types of blood cancers. So as far as the transmission goes, this is really what this class is all about. There are 5 bodily fluids that are capable of transmitting the virus. You have blood, semen, pre-ejaculate, vaginal fluid, and breast milk. These are the ones that contain the highest viral loads of HIV, and these are the ones that can transmit. Now, the transmission of AIDS from an infected person to a non-infected person, it depends mostly on 2 things. You have to have a vascular exposure to infected blood, so that to one of the 5 infected fluids. So you have an open cut, you have an injected site, something along those lines, and you have to be exposed to that particular pathogen. And then the fluid that contains it has to have a high enough viral load to transmit the disease. So somebody who's in the very early stages of HIV, they're not going to have a very high viral load. Chances of transmission are far lower than if somebody has a higher viral load. So just some statistics on the transmission of HIV. About 53% of the cases are transmitted by male-to-male homosexual contact. 32% are from high-risk heterosexual contact. About 17% are through IV drug abuse, so your heroin abusers, your meth abusers, things like that. And then only about 1% of the cases are transmitted through the other means. These would be the means that we would be exposed to as healthcare providers. So blood transfusions, organ transplants, needle sticks would be the big one. There's only about a 0.3% chance of getting HIV through a accidental needle stick. So the chances are still pretty low. Obviously, with the horrible nature of this disease, with its 100% mortality rate, even a 1 in 333 chance is still pretty bad. So those are not odds that we like to play around with, and there will be aggressive occupational health actions taken after the exposure. So some of the specifics about HIV, the virus itself. HIV can't reproduce outside of a living host. It's a very weak virus. It doesn't survive very well in ambient room air. In a dried bodily fluid, it'll die within about 1 to 2 seconds. It's very fast. So once those fluids dry, there's really no risk for transmission of HIV. So suppose that you come in contact with dried blood on a seed or something along those lines, you have 0 chance of contracting the disease based on that. So even if you get stuck with a needle that's still got some wet blood on there, there's really not a very big chance of contracting it. You'll still need to follow up with your OC Health, and they'll advise you accordingly based on that. Some of the other bodily fluids that we come into contact with quite often, you have saliva, you have mucus, tears. The virus doesn't concentrate in these fluids, or if they do, it's extraordinarily minimal. There have been 0 documented cases of anybody contracting the virus based upon these fluids. So if you do get exposed to spit or mucus, it's pretty nasty, it's disgusting, but you don't really have a chance of contracting the illness based on that. And then, of course, exposure to a virus on environmental surfaces. Even with extraordinarily high viral loads in fluids produced by the CDC, these are called supercharged fluids, even that only survived about 5 to 10 seconds on those ambient surfaces. So, very weak virus. The other one that gets asked quite frequently is insect bites. Somebody bites an HIV-infected individual and then comes over and bites me, will I get the virus? The answer is no. There have been no transmitted cases under those circumstances. For a couple reasons. Number one, HIV doesn't live in the saliva of insects, so it kind of stays within them. They're also immune to it. And when an insect bites an individual, they don't inject any of the previous person's blood. So there's no risk of getting from that. And then, kind of most importantly, insects don't really bite one individual and then go to another to feed. Usually when they feed off of one, they're done for a little bit, so not really much of an issue there. Yeah. Questions on AIDS or HIV or any of those? Keep on going?
Sure.
All right. So I'll talk about hepatitis next. Hepatitis is probably the second one that we worry about in addition to the HIV. Hepatitis itself, hepatitis just refers to liver inflammation. That's a descriptive term for it. That's all it really is. Hepato is Greek for liver. Titus is, I think, Latin for inflammation. So the viruses that cause it are different from the other causes of hepatitis. We've heard of alcoholic hepatitis. That's not a contagious disease. That merely refers to liver damage caused by alcohol. There are several other causes of that as well. The 5 that are most prevalent throughout the world are labeled A, B, C, D, and E. We're just going to talk about A, B, C because those are really the only ones that are prevalent in the United States. So they are different in terms of their transmissibility, in terms of the way that they are introduced into the human body. They just about all of them have the identical signs and symptoms. There are 2 phases of this. There's what's called the prodromal phase, or the early phase of the infection. This is when your immune system basically activates and tries to kill it off. So you wind up getting flu-like symptoms. So this is your basic nausea, vomiting, diarrhea, loss of appetite, low-grade fever. And then as your body progressively tries to kill the virus, you wind up getting liver damage. The viruses themselves, they concentrate in the liver, and it's actually your immune system attacking the virus that causes the damage to the liver. They attack the virus, but they also attack healthy tissues, which causes liver impairment. So this is what's called the icteric phase, and this is where you start to get a lot of the yellowish discoloration of the skin, a lot of the signs and symptoms of liver impairment or liver failure. So you'll see a yellowish discoloration in the skin, the eyes. What this yellow discoloration is, it's the liver being unable to filter damaged or dead white red blood cells. So if you've ever noticed, you get a bruise. In the beginning stages, it's a dark purple, and then it kind of progresses to green, and then finally it's yellow. That's the iron component of the dead red blood cell kind of lingering there for a little bit. What happens in liver failure is that your liver doesn't process those anymore, and it becomes apparent in the skin and the eyes, and those can become toxic after a little bit. So liver damage occurs incidentally. There are really 2 fates to the icteric phase. 2 things that your body can do. Either one, your immune system can defeat the virus, and then after that it'll develop antibodies and will defeat it again if it becomes exposed. Or the liver can become damaged to the point where it doesn't function anymore, where you're in a state of liver failure. This is called Fulminant Hepatitis, and this is where your liver can't recover. You get cirrhosis, you get profound impairment, and the only cure for this is really liver transplantation. So 3 types of hepatitis we'll talk about. I'll start with hepatitis A. This was really the only known type of hepatitis prior to the late 70s and the early 80s. This was called infectious hepatitis, and then once hepatitis B and hepatitis C and all the other ones were discovered, that's when it got called hepatitis A, so that it could be labeled more appropriately. So hepatitis A, in contrast to HIV, it's a very resilient virus. It does survive in dry bodily fluids. It does survive on environmental surfaces. It's one of the most resilient viruses there are, and it does survive in extremes of temperature as well. So -4 degrees to about 132 degrees Fahrenheit, it can live in those extremes of the environment. So that's the bad news. The good news is that it's only transmitted via the oral fecal route. And we do have vaccines that can pretty much grant people immunity from the virus for the rest of their lives. So oral fecal, if you do get exposed to blood, it doesn't get transmitted that way, so you have 0 chance of transmission for that. This really is prevalent in environments where there's very poor hygiene, or it's very unclean, where I guess people don't shower that much, they don't clean themselves that much, and that's really how the virus thrives. Cleaner environments, people who have better hygiene, it really doesn't survive, and it really doesn't get transmitted in that. So the number one preventative measure for this is going to be vaccinations. Vaccinations can provide near 100% immunity for the rest of their lives. With improvements in hygiene, sanitation, and with the provision of vaccinations, HIV rates have dropped dramatically in the last 20 years. It's very uncommon to see those anymore. So with that in mind, with the transmission criteria, it's not uncommon to see that in people who live in close quarters, so low-income households, prisons. It's prevalent in nursing homes, and then third world countries that don't have the aggressive public health policies, it's not uncommon to see them in there. For example, India and China, it's very prevalent in those countries because they just don't have the public health programs to address it. So even if you do contract hepatitis A, it's not very commonly a lethal disease. 1% of individuals, every single age, is just about all that it kills. Number one determining factor in mortality is going to be age. So the older that you are, the less you're able to fight off the virus, and the more vulnerable you are to develop the hepatic impairment effects. Over the age of 50, it has a 2% mortality rate. The antiretroviral drugs and the treatments that they have for hepatitis A are pretty effective, and usually not that aggressive treatment. So hepatitis B, this is also called blood-borne hepatitis. This is the form of the hepatitis B virus. This is the form of the hepatitis virus that lives almost entirely in the blood. It's probably among the most common infectious diseases on the planet. About 1/20 of the world population is either a carrier or is actively infected with it. So we see about 200,000 new cases of hepatitis B in the U.S. every year. People who have been vaccinated for it are virtually immune for the rest of their lives. So most of these cases are present in people who have never been vaccinated for it. A lot of people from foreign countries who don't have the vaccinations, who don't receive them when they're born or when they're in infancy. These are most of the people who contract hepatitis B. 5,000 people die of hepatitis B annually, and about 250,000 in the world every year. So it's almost exclusively present in the blood, and it is very highly transmissible. If you don't have a vaccine if you haven't been vaccinated for hepatitis B, and you do get stuck with a needle, you have about a 30% chance of infection. It's an extraordinarily resilient virus. It's probably the most resilient virus on the planet. At -15 degrees Celsius, hepatitis B can survive about 70 years. So it's really incredible. Room air, ambient room temperature, it can survive about 6 months to a year. So it does survive quite a bit. Good news is that hepatitis B vaccines are readily available. Every single time that an employer hires somebody in a healthcare environment or an emergency care environment, they are forced by law to offer the vaccine to anybody who they hire. So if you haven't been vaccinated for hepatitis B, contact your occupational health, talk to Chad. They'll be able to arrange that for you. All of you should have been offered that vaccine when you got hired though. So most are immune to hepatitis B for the remainder of their lives, and it is a 3-part series. So you're giving it 1 day, and then a month from that date, and then 6 months after that. So hepatitis B continued. So if you do, for whatever reason, opt to decline it, they'll document that accordingly as well. Just about every single child born after the age of 1990 has been given this vaccine after they're born. So the incidence of hepatitis B is really dropping dramatically. So hepatitis C, this is another one that we tend to worry about quite a bit. This is probably the most concerning one after HIV and AIDS. We don't have a vaccine for hepatitis C, so its incidence is fairly large. It is a fairly resilient virus, though not nearly as much so as hepatitis B. So it does live in the blood products. It can be transmitted through open skin, and it is present in semen, so it is a sexually transmitted disease as well. It's very common throughout the world. They estimate about 200 million people have it, and 200 million people are carriers as well. 4 million people with hepatitis C in the United States, and about 70% of those go on to develop hepatitis. So while it's not nearly as resilient as hepatitis B, its effects are far more damaging than those of hepatitis B. Hepatitis B, even if you do contract the illness, your immune system should be able to fight it off. It should be able to develop antibodies. In most cases, that'll be the case, not nearly as much so as hepatitis C. About 30% of people who get exposed to hepatitis C, their immune system does beat the virus. They do develop antibodies for that, and it's usually not a problem after that. 70% on the other hand, they do wind up developing chronic hepatitis. So 10,000 deaths every year. That number is expected to rise. 30,000 cases of hepatitis C are diagnosed every year, and it is the #1 cause of liver transplantation. Also causes liver cancer eventually down the line, so that is another cause for concern. So, along with AIDS, hepatitis C really became prevalent in the U.S. in the 1970s and 1980s. They were noticing that a lot of people who were receiving blood transfusions were developing this form of hepatitis that wasn't testing positive for hepatitis A or hepatitis B. They called it non-A, non-B hepatitis. So they knew that there was some other strand of hepatitis going around, though they couldn't identify it. Once they isolated the virus and were able to examine it, that's when they called it hepatitis C. They're estimating that between the years of 1979 and 1984, along with those 90% that received HIV, about 300,000 cases received hepatitis C as well. So it was a very alarming thing, and that was another reason why they developed such strict screening protocols for blood donors. So it's far more virulent. So the main ways that it's transmitted, IV drug abuse is the biggest one that accounts for about 60% of the transmissions. High-risk sexual activity, it's about 20% of the transmissions. And acupuncture, tattooing, piercings can be passed from the mother to the fetus upon birth. And then blood transfusions with the advanced screening protocols, it's about 1 case in 100,000. So they really got good screening of blood. Anytime they get a donated blood sample, they test for it. They test for HIV. It's a very rare thing to contract any of these diseases from a blood transfusion anymore. If you do get stuck with a needle, which would be probably our #1 mode of transmission, along with AIDS and HIV, it's about a 0.3% chance of contracting the disease. So still pretty low. Depending on the extent of your exposure, if you just got scratched with a needle, they probably won't activate any type of post-exposure prophylaxis. If you wind up stabbing yourself in a vein, that would be far more concerning, and your occupational health agency will develop a plan for that accordingly. So currently no vaccines, which is probably why it's spreading so much. People aren't developing immunities, and it is a very easily transmissible disease. So good news with that, people with chronic hepatitis are usually asymptomatic for the remainder of their lives with the antiretroviral therapies, etc. So it's not really all that impairing to daily living, but they do pose a risk of transmitting it to other people. Questions on the hepatitis? Move on. All right. So tuberculosis, that's another one that's really a big cause for alarm in the healthcare environment, the emergency services environment. It is a very contagious disease, and it does wind up killing more people in the world than any other infectious disease. It's in the top 10 cause of death every single year. Kills about 7% of the world's population every year. So, it accounts for 7% of all the deaths in the world. So, 8 million people contract it every single year. Tuberculosis, it's a respiratory ailment. The bacteria that causes it concentrates in the lungs. In people with good immune systems, the immune system will be able to isolate it in the lungs, and it'll be able to kind of quarantine it if it doesn't expel it right away. So they say that there are about 3,000 droplets that are produced with every single cough. Every time you expel a cough, there are about 3,000 droplets. As few as 10 can spread the disease to the affected individual. So the criteria for contracting it, the things that will make this disease transmissible, it's going to be the number of organisms per cough. Just like HIV, the lower the load of the bacteria or the pathogen in the transmitted fluid, the lower the chance that you'll contract the disease. Similarly, the concentration of the organisms in the droplets, the duration of the exposure. So if somebody coughs on you once, you may or may not be at risk for it. If you're spending hours or days or what have you within that environment, much greater chance of contracting it. And of course, the immune status of the exposed individual. So people with chronic TB, they'll usually go through about 2 stages of the illness. The signs and symptoms of active TB, you have a cough with blood-tipped sputum, that's a telltale sign of it. Then, of course, you got your flu-like symptoms, so your chills, your fever, your loss of appetite, weakness, weight loss, chest pain, and then night sweats is another one. Night sweats you'll also see in people infected with HIV and hepatitis C. During the latent stages of TB, so the bacteria has been effectively quarantined, they're not going to be having any cough or anything like that. They'll be carriers of the bacteria, but they're not going to be expelling it. They're not going to be contagious after that. So during the latent stage, there's no risk of transmission. So supposing that you do come into contact with somebody, they do have a previous history of TB, they tell you that they're not coughing, they're not sick or anything like that, there's no chance of contracting TB from that individual. They have to cough, and that cough has to contain the bacteria. So it has to be a productive cough for that. People with healthy immune systems, they'll usually defeat the bacteria pretty easily, and then they'll have antibodies thereafter that. Do they do a PPD skin test, Jeff, before they get hired? No. No? There is a test to determine if somebody's been exposed to the bacteria previously. It's called the PPD skin test. It's also called the Monto test. Basically what they do is they take a living but weakened form of the bacteria, and they'll inject it subcutaneously. Within about 2 days, you'll either have a completely healed up spot, or it'll be red and it'll be swollen and it'll be exhibiting signs of infection. What that basically is if you've been exposed to the bacteria before, your immune system will recognize it and it will attack it. So if you do wind up getting that increased redness, that swollen spot, it means that you've been exposed before, that your immune system is attacking it. If you haven't been exposed to it before, it'll just kind of go about its normal course, and you won't necessarily have it. What this does is it lets you know if the person might be in a stage of latent tuberculosis, or if they've ever had a case of active tuberculosis. It doesn't mean that the person has tuberculosis, it just means that they've been exposed before. If somebody tests positive for that, usually what they'll do is they'll do chest x-rays for 5 years for the rest of their life. So that'll help to determine if they have little patches in their lungs, if the disease is developing, or if nothing in particular is going on with that. So and then only a sputum test will determine if the person has active TB. So if somebody has a wet head and cough, they will expel the sputum, they'll expel the bacteria, they'll test that, and then they'll look for the active form of the bacteria. So some of the most common populations, individuals who are HIV positive, they have about a 200 to 300 times greater likelihood of contracting the illness. And that, again, that's because their immune systems are compromised, their immune systems aren't reacting to the invasion of the bacteria, and it's allowed to grow and develop much more effectively. Tuberculosis, incidentally, is one of the leading causes of death for people with HIV. People who are homeless, people who emigrate from other countries. The CDC and the United States Public Health agencies, they're very aggressive about treating tuberculosis. If somebody tests positive, a representative from the CDC will show up to that person's house every single day, make sure that they're taking their antibiotics, and make sure that they're not developing a drug-resistant strain they're very aggressive with this. Some countries, quite a few actually, they don't have programs in place that are really aggressively treat this. TB will spread from individual to individual in those particular places. So antibiotics are usually sufficient. They'll defeat the bacteria and then they'll eliminate the original strain. They'll develop antibodies accordingly after that. Because of the mismanagement of tuberculosis in the past, because antibiotic courses and regimens weren't followed all that well, the bacterias, some of them have developed immunity to the antibiotics themselves. So this has resulted in multiple drug-resistant tuberculosis. The classic antibiotics for this won't be successful in defeating the disease. So they'll need more intensive antibiotic regimens in order to treat it. So, and then further mismanagement has caused another strain of tuberculosis called extreme drug-resistant tuberculosis. This is impervious to every single antibiotic out there, and they'll usually die within about the course of 3 to 4 weeks. So, really nasty stuff. Good news is, most people with good immune systems, most people who receive the antibiotic treatments, they'll defeat the bacteria pretty easily. It won't really be living in their lungs, and they'll go about their normal lives. They'll test positive on the PPD skin test every time, but as long as they get a chest x-ray every 5 years, as long as they are managed appropriately, nothing will really happen. So we do have personal protective equipment that will protect us from this. The number one recommendation is the HEPA N95 mask. What the HEPA mask does is it blocks about 95% of the inhaled particulate matter. They do manufacture masks that'll block a little bit more. They have the N97s and they have the N99s. But the N95 is considered sufficient by OSHA. So surgical masks, they don't really block the individual, the healthcare provider, from inhaling those droplets, but if you put them on the patient, it'll also block out the droplets and it'll block their transmission. So N95 mask for the healthcare provider who is treating that patient, and then the surgical mask for the individual who potentially has a risk of transmitting TB. So if you are treating somebody, you suspect them to have tuberculosis, they're complaining blood-tinged sputum, they're having all those symptoms, you're going to want to don those masks right away. You're going to want to put them on your patients right away, and then you're also going to want to alert the appropriate authorities. You'll contact your public health individual. You will contact the emergency department so that they can set up a room specific to tuberculosis. It's called a negative pressure room. It'll basically suck in all the droplets that person expels, and it'll keep it from going in the ventilation system. So just inform your appropriate authorities. If you do have a potential exposure, follow up with your occupational health agencies. What they'll do is they'll do a PPD skin test right away to determine if you've ever been exposed to the bacteria before, and then several weeks later they'll give you one to determine if you were exposed to that particular case. If the second one is negative, it means that there was no exposure, no harm, no foul, and you're good to go. So, questions on tuberculosis? Moving on. All right, tetanus. Tetanus is the other one that we tend to worry quite a bit about. A lot of people worry about it with lacerations or punctures with potentially dirty objects. What tetanus itself refers to is muscular tightness, stretching forces. It's also commonly known as lockjaw because of the effects that it has on the jaw. It results in a descending paralysis from the top of the head down to the remainder of the body. First muscle system that it tends to manifest is in the muscles. So tetanus is caused by a particular type of bacteria called the Clostridium tetani. It is a very resilient type of bacteria. It can survive without oxygen, and it is present on a lot of surfaces throughout the environment. Most commonly in farming or rural environments. It's present in a lot of animal feces, cow and horses, and cats, dogs, and then it's present in some of the other environments as well. So it's contracted it's contracted basically when you do get an exposure through a cut or an open sore. It doesn't necessarily have to be a particularly dirty object. It can appear clean. A lot of the rumor is that if you step on a rusty nail, that's an increased risk for tetanus. That's not necessarily true. So it can be a clean object, it could be a dirty object. It just depends on if the bacteria is present in those. So the good news about tetanus is that the tetanus vaccine is 100% effective. Anytime that you cut yourself, you go into the emergency room, they'll ask you when the last time you had a tetanus shot was. If it was within the past 10 years, you're considered immune to it. You won't contract the disease. You'll be just fine. If it's greater than 10 years, they'll give you a tetanus shot prophylactically, and that'll eliminate any chance that you have contracting it. So tetanus is pretty prevalent throughout the world. However, with the implementation of the tetanus vaccines, there have been about 31 cases per year in the United States for about the last 10 years. And every single one of those either did not keep up on their tetanus regimens or they never got a tetanus vaccine to begin with. So if you've had it, if you've had tetanus vaccines, you're good to go. You have no risk of contracting it whatsoever. So, questions on tetanus? All right. Lastly, I will go over OSHA's requirements on infection control plans, occupational exposures. Every single person who works for an industrial environment, an emergency care environment, they have the right to access the exposure control plans at all times. There should be a copy available to you if you want to look at it. I'm sure you can. Chad, I'm sure, has access to it. Several of the other individuals as well. So what they'll do for an occupational exposure, first of all, they'll evaluate the criteria of that exposure. So if you've been exposed to blood, mucus, saliva, it depends on the type of fluid that you were exposed to. If you've been exposed to blood, this is when they'll do the HIV and Hepatitis C screenings, and this is when the Bryant-White Care Act will come into effect. They'll draw the source as well. The source themselves, there's been some question on this. They have absolutely no right to refuse that blood draw whatsoever. So if you've been exposed to them, they will hold that person down on a gurney if they have to. So you always have the right to know if they possess any type of potentially lethal disease. The way that they'll determine it, blood exposure is pretty obvious, but it really depends on if it's kind of splashed on your skin or if it's gotten into an open cut. Accidental needle sticks, that'll be automatic criteria for a post-exposure thing. If a little bit splashes on your skin, most occupational health agencies consider that to be not really an exposure whatsoever unless you have an open cut around that area. Skin should be effective in blocking just about any type of blood-borne pathogen. So the exposure control plan, like I was saying before, every single employer in emergency healthcare has to implement they have to offer the Hepatitis B vaccination, and then you will either have to accept the Hepatitis B or you can decline it. There will be extensive documentation if that's the case. So big things that they put into effect are going to be your personal protective equipment, your standard body isolation. The employer also has to make these available free of cost, no cost to the employee. These will include gloves, these will include gowns, face masks, surgical masks, goggles. It's the role of the employer to offer you all the equipment. It's your responsibility to make sure that you are appropriately protected from this. So there has to be readily available hand washing stations, and then the personal protective equipment that we talked about. So they always have to be made available to you. So the other thing is housekeeping and environmental services. You're cleaning up after a scene, or you're cleaning up after there's some sort of blood or bodily fluid. Your employer has to make available the red biohazard bags, and they have to indicate which ones go where. So your normal paper towels or your normal garbage, they can go into the regular garbage bags. Anything that has bodily fluids on it, they have to go in the red biohazard bags. And again, your employer has to do that free of charge. So contaminated sharps. Every single sharps that are manufactured nowadays, they have protective sheaths on them. Your IVs have a sheath that will drop back and will lock the needle into place. Every single needle that is made for drawing up medications or administering IM injections, they have to have a needle guard on them, which you throw on right afterwards. So contaminated sharps,
should not be an issue unless the needle has been left exposed. So needle stick safety, again, this will be a post-exposure thing that you go to with your occupational health agency and clinic. So if you ever do have a malfunctioning needle, if the needle doesn't retract in the IV catheter all the way, or if you have some other form of shark that should offer protection, but for whatever reason it fails, save that and then contact the manufacturer, because there might be other sharks out there that have that potential defect as well. So, yeah. That's about it. Any questions on anything? No? That's all I got.